Assalamu alaikum, good afternoon. Thank you for the introduction. My name is AHMED KHARUSI. So I was planning to go deep in this topic, but since we have like multi-specialty in the room, I went to the basics, so I changed my whole presentation. Okay. First of all, what is atrial fibrillation? Mainly atrial fibrillation, as you can see, is irregularity. It is a chaotic atrial activity. So the atrium is working in a chaotic way. It's not regular at all. And the heart or the ventricle is beating randomly. It increases stroke 5 times. It is the reason of 30% of arrhythmia-related hospitalizations, and it reduces also 30% of the blood going from the atrium to the ventricle. What are the management strategies? So we have goals to follow. Number 1, to control the symptoms of the patient. Number 2, which is very important, to prevent stroke. And the third one is to prevent complications. In regard to symptom control, now we have 2 strategies for each patient, whether to control the rate or to control the rhythm. So I will start with the stroke prevention. If the atrium is beating like fast, very fast, it cannot eject the blood from the atrium to the ventricle. So the blood is pooling here. Around 30% of the blood is pooling in the atrium, mainly in the left appendage, and blood tends to clot there. So that clot can move from the atrium and go to the bloodstream and go to whether the brain and to stroke or to the kidneys and cause a lot of failures in the body. So how to prevent that or how to treat that? With medications mainly. So we will start with direct oral anticoagulants. If it is contraindicated or it is not working, we will move to warfarin. If it is not working as well, we'll use occluders. So mainly what is occluders? We will remove the left appendage, whether to close it with a closure device, or to cut it, or to suture it. Any way or anyhow to prevent the clot coming outside this appendage. So this is the first thing. We finished from stroke prevention, and now we'll go to the symptom control. How to control the symptom? The first one is to control the rate. This is the first strategy. And we have a different strategy, which is to control the rhythm. What is the difference? Mainly these patients are in atrial fibrillation, as you can see. But this patient, his ventricle is responding in a regular rate. The rate of the ventricle is normal. This patient here, his ventricle is active. So the AV node is sending the pulses to the ventricle, and he is in tachycardia because of the atrial fibrillation. This patient, no, his AV node is not working much, so he looks like in bradycardia. So these 3 are in atrial fibrillation. But for this patient, I don't want to control anything in regards to the rate. The rate is good. For this patient with the tachycardia, we need to control the rate. So mainly, I am controlling the rate, but the patient will be in atrial fibrillation. In the other option, which is rhythm control, I will change the atrial fibrillation to sinus rhythm, back to sinus rhythm again. Okay. What is the difference? If I want to control the rate, I will use this option for stable patients, and I will use medications. What are these medications? As you can see, mainly this medication to slow down the AV node. That's the reason of these medications. In the other option, which is rhythm control, mainly I want to change the atrial fibrillation back to sinus rhythm, and I want to the SA node to control the heart. And for this, we will start with anti-arrhythmic drugs. If it didn't work, or the patient is symptomatic, I want faster solution, I will use cardioversion, and there is an option of catheter ablation. Okay? So, the medications, this will control the rhythm and change the rhythm from atrial fibrillation to sinus rhythm. If it is like the patient is hemodynamically unstable, we will go to the other option, which is electrical cardioversion. What is cardioversion? It is similar to shocking the patient, but we have to have synchronization. We will not shock the patient anytime except over the R wave to prevent ventricular fibrillation, and with the low joules. We have to take consent, we have to sedate the patient, and we have to make sure there is no clot in the atrium, because after cardioversion, that clot will move, and for sure it will cause stroke. Okay. Now the third option, which is the main topic, the catheter ablation, which is the definitive rhythm control strategy. But first of all, what is ablation? Do you know what is ablation? Everyone knows what is ablation? Mainly to burn places in the heart, so it will not cause the rhythm that which we don't like. But for atrial fibrillation, where should we ablate? What do you think? In fact, no one knows what is the source or what is the reason of atrial fibrillation. Still, until now, there are studies, but no one knows what is the source of atrial fibrillation. And these are like, some doctors, they think it is pulmonary vein is the source of atrial fibrillation. Some of them, they believe that it is mitral re-entries, and they call it rotors. Some, they think it is from the ganglion plexi. Some will think it is from the ligament of Marshall. That's why each doctor will ablate in different places. I will go, or the rule of thumb, they will start all of them, or most of them, with pulmonary vein as the source of atrial fibrillation, and they will go to the pulmonary vein and isolate the pulmonary vein. As you can see, these are 4 pulmonary veins. The anatomy of pulmonary vein is there's like muscle inside it, and see the muscles around it. So this is the source of atrial fibrillation. So isolation mainly is to ablate or to burn the tissue around the pulmonary vein from both sides, and any electricity coming outside from the pulmonary vein, it will not reach the heart. So no atrial fibrillation anymore. Let the beats be inside the pulmonary vein without affecting the atrium. So we have different techniques. The first technique is point-to-point ablation, where we take the catheter and go to this tissue and burn it here. This is RF ablation, radio frequency ablation, and we'll start burning around the pulmonary vein, and then we'll go to other one, third one, fourth one. Of course, it is from we should go to the left side, since pulmonary veins, all of them are in the left side. So we'll go point by point and start burning the tissue around it. So anything inside the pulmonary vein electrically will not move to the atrium. Now, they try to improve that, to make it faster. And they created something called cryoablation, where you inflate a balloon, you just stick it in the pulmonary vein, it will touch the whole surface around it, and you just ablate. But how to ablate? They decided, or they designed a way that we can ablate using freezing.
1 minute.
Inshallah. So we freeze the tissue until the tissue dies. But unfortunately, this didn't work very well, and most of the patients, the fibrillation will come back again after a while. Now, the latest technology, which is in the market now, which is pulsed field ablation, where you submit pulses to the tissue and it will damage the tissue, as simple as that. And this is the procedure. It's done. It is done in 20 minutes only. And these are the companies who created this technology, or who are using this technology. So mainly for management, you need to assess stroke risk, determine the rate or rhythm control, which strategy you want to use, and consider medication, cardioversion, or ablation. Thank you.